Thank you so much for having me. I'm really honored to be able to talk about a subject that's really close to my heart across the country in partnership with the National Hispanic and Latino Mental Health Technology Transfer Center. I've had the honor of knowing a few of the faculty staff over there for several years and have really enjoyed learning from you guys. So it's a pleasure to be here sharing what I know as well. So what we're going to talk about in the next, I don't know, 60 minutes or so are really a hodgepodge of things that I thought would be important for folks who may just be starting out working with interpreters in a clinical setting, or who are really kind of interested in the subject as it relates to kind of the therapeutic environment. But before we start, we really can't kind of talk about this without exploring what's happening right now with language access, with interpreting, and with folks who are limited English proficient during the COVID-19 pandemic. So we thought about doing a little research on the current status of those topics and sharing them here as a first part of our discussion. Then we're going to talk about why trained interpreters are critical to effective communication in a clinical setting. I could be preaching to the choir. It looks like a lot of you already do work with Hispanics and Latinos, and some of whom may have limited English proficiency. So you may just hear what you already know to be very, very true. I also want to talk about some of the common practices of trained interpreters. My philosophy is that the more a clinician knows about what's expected of an interpreter, the better they're able to guide an interpreter in how to help them communicate effectively. And then we're going to talk about some strategies for working with interpreters, particularly untrained interpreters. So if you are in a situation where you've got to use a family member or perhaps a community person who doesn't have training, you may be able to help them with their success. And then we'll talk a little bit conceptually about the impact of interpreters in a mental health or a behavioral health setting, some of the research that's been done, and some of the experiences that I've observed in my work around this topic. So let's get started. You know, really thinking about COVID-19, there's really no event in the last 100 years that's highlighted the health inequities in the U.S. more than COVID-19. It didn't take but a couple of weeks for news reports to start popping up with things that a lot of us in the health equity field already know, and that's that Black and brown communities are being affected disproportionately by the pandemic. It really highlights how our structural, organizational, and even individual equities are causing people in Black and brown communities to be more sicker and more vulnerable. And really every day we're learning a lot about these disproportionate impacts. So I wanted to share some of the news articles and some of the things that are being talked about currently. From these statistics, I'm not going to read them all, and you may not have a chance to read them all while we're on this slide, but I know that you'll be getting these slides at a later point. And we can see that without a doubt, Latinx communities are disproportionately affected by the virus, with higher rates of illness and death per capita than white populations. And you know, why are we seeing some of these inequities? Most people who study this phenomenon recognize that there are really three important factors that make Latinx communities more vulnerable. First of all, Latinx workers are found in higher numbers in job classes that include frontline health and human service support, and also are often considered essential in nature during the pandemic. We can think about everybody from Uber drivers to Kroger cashiers. In fact, yesterday I was listening here in my own state of Virginia that the governor of Virginia, Northam, said that 60% of all the cases tested positive of COVID in Virginia were Latino or Hispanic patients. We have a huge meat packing and processing industry here in the state. The vast majority of employees in that industry are Latino, and we're seeing the impact for them very clearly. The second important factor around why Latinx is more vulnerable is related to how Latinx communities suffer often more from chronic diseases at a disproportionate rate already prior to the pandemic, of course. So things like heart disease, diabetes, hypertension, obesity, those are things that that allow the person with those chronic illnesses to be more vulnerable to being susceptible to COVID and actually having a higher death rate because of how COVID can impact people with chronic health conditions. And lastly, the last important factor, not the last, but one other important factor is that Hispanics have the highest uninsured rates of any racial or ethnic group in the US. And most of us know that if you're uninsured, you receive less medical care, you have less timely care, you often have worse health outcomes, and the lack of insurance is a health and fiscal burden on everybody in the family. So there is less likelihood to seek out health care if the economics or the finances don't work out. So given these statistics, it's really no wonder that the Latinx communities are suffering disproportionately in this pandemic. So I want to drill down a little bit on one subsector of the Latinx population, trying to build an argument about why we focus on limited English proficiency when we talk about Latinos. 64%, or about 16.2 million people in the US speak Spanish. So this is from the Migration Policy Institute. It's a little old, it's from 2013, so the likelihood that this is increased is very good. You can see that from this chart here, Spanish is the language spoken vastly more than any other language in the US. So other languages spoken lag way behind that of Spanish speakers. I think in here you can see that it's Chinese is at 2%. Last I heard it was at 3%. So so if you're thinking about 64% and then the next most prevalent language is Chinese, then the argument is that what we're talking about when we talk about limited English proficient individuals, or if we're talking about populations who are English language learners, we are really talking essentially about Latinos, both native born and foreign born in the US. We also know that these populations, the LEP, limited English proficient, or ELL, English language learner populations in the US, their limited English abilities make them a more vulnerable population, particularly when it comes to the healthcare system. You can see from this chart, which is a graphic created from a study by the Joint Commission, shows that patients with limited English proficiency experience adverse health outcomes at a markedly higher rate than English speakers. They are more likely to be admitted to the hospital. They're more likely to have longer stays. They have higher rates of medical errors with worse clinical outcomes than English proficient patients, and often receive lower quality of care by other metrics because the communication is such a challenge. And these studies, there's studies also that show that when asked related to things like customer satisfaction, persons with limited English proficiency also perceive themselves that they have a poor patient-physician relationship or interaction when compared with people who speak primarily English. So we're talking about a very vulnerable population that's very isolated, that has a great deal of barriers to receiving care, accessing care, and continuing to ensure their health and wellness. These news clippings are just, clipped from headlines that I had been looking around at, and what we're seeing in these news clips is that COVID-19 is having, not only is it having a bigger impact or an impact on folks who don't speak English, but it's actually bubbling up in mainstream media, which is really interesting to me. For those of us who've been following language access services for decades, the idea that this is even news right now is pretty interesting. It actually gives me some hope that that in healthcare and in mainstream sort of values, we're starting to think about how language barriers impact people in just their everyday lives. So let's look at a few of these passages from these news clippings that I've collected. In these passages, you can see that people who are sick with COVID and the communities that are concerned with COVID are really at a disadvantage when they don't speak English. These are not new issues. We have really had a bad history of planning for language services in healthcare. But when a crisis hits, of course, it just makes it all that much more problematic. So these clippings here, as you can see, are really talking about how folks with limited English proficiency their services may be delayed, and in the rush and the heat of the moment, people who can communicate effectively may be getting better services. They're also recognizing that folks who speak limited English are also having limited information shared with them. I know that public health departments all over the country are working really hard on making sure that there is information about coronavirus available. It's just a sort of a matter of fact that much of that information doesn't trickle down to the folks that need it. And just as there's a heavy toll for medical providers during the pandemic, the same thing is happening to interpreters working with those providers. I think you guys have heard the same news articles that I have about providers who are really suffering. Their mental health is really suffering from just the devastation in communities. And I just wanted to remind you that part of a health team, whether they're recognized or not, are interpreters, and they have less background in sort of understanding how to cope with crisis and disaster than many providers in a professional healthcare setting do. So the trauma that is being sustained by interpreters is very significant. Not just the trauma related to what's happening, but interpreters are saying that they're affected by trauma in many ways. They're worried about their own families. They're worried about their finances. Many interpreters are contract staff or they're self-employed. And so the shift has really impacted them financially, as well as so many other folks in the US. I've also read that interpreters are also facing the same sort of lack of personal protective equipment that providers are to keep safe. and oftentimes they may not be have as much knowledge about the importance of those kinds of PPE to keep themselves safe. And lastly, interpreters are talking about sort of the struggle to shift technology, whether it's their own shift to virtual interpreting, or it's the people they're serving, the patients they're serving, inability to access the technology or not have the right technology to do it well. So this is impacting everybody, including folks who often fly under the radar. So try to give you a picture here of the current environment for interpreters, and I would invite you all at all times to throw up your own experience in the chat box, in the polls, or I believe it's in questions is where they're being asked. At any rate, I'm not the only one who has any experience with this. There's certainly plenty of people who do, and so I'd love kind of as a record of those experiences that you guys put them in the chat box and share with us. We can all learn from each other about these things. So what I've tried to do really is give you a picture of how interpreters are connected to the well-being of the Latino community at large, and a domino effect like the pandemic is having on these communities. What I have shared really highlights the fact that the healthcare industry really needs to plan better for language access services, and the planning needs to take place much more early. We can't wait for a crisis like COVID-19 to hit. And if systems did do more planning, a lot of this can be avoided. I used to say when I did training for the state that there really should be no interpreter crisis or interpreter emergency, because if communities are thinking about who's in their community, the languages that are being spoken, how they can help develop the interpreter workforce and plan for translated material, they'll be ready to pull it off the shelf at any point, and there won't be cases where people don't have access to the information that they need. Some ways that you can do this, is just a really quick plug, is to make sure that organizations have formal language access plans. Make sure that when you're doing crisis planning or crisis management planning in your organization or in your community, that you're including language access, you're including interpreter considerations, you're into your tabletop emergency exercises, which happen in communities all the time. And then organizations can also make sure that there's always ongoing upgrade and budgeting for interpreter technology across the system. You can always, I used to go into facilities and I would see that there are phases of when they paid attention to language access. So maybe at one point in time, they spent money and they upgraded all of their telephone systems to make sure that they could have interpreter services on them. And then the technology changed, and those telephones, those handheld telephones, became obsolete and they never got used, and they got thrown in a closet somewhere, and they failed to update to the newer technology. So in a nutshell, I just really feel that emergency management systems in communities, and particularly in hospitals and state health agencies, really have to do a better job at planning for language access services. And when they don't, and they wait until it's a crisis, then it's just way too late. So I'm going to shift gears now, and we're going to get talking about the purpose of this webinar today. That is really the goal of informing providers of all types. It looks like a lot of you all are clinical folks, but some are not. And just kind of informing you all about the ways that you can work effectively with interpreters, and a little bit about how we would do that in a behavioral health care setting. So let's get started. Now, I know I've already started using some language that may not be familiar. And I plugged this slide in at the last minute because I realized as I was walking through the slide deck that there's a lot of language that is kind of within the profession that may not be familiar. So forgive me, Daris and Isa and everyone else that I plugged this in at the last minute. But I did want you to know, first of all, I use these terms way too much in this webinar because we keep going back to explaining scenarios. And hopefully you'll start to think about them and the way that you can use them to help define and frame what interpreting services are. So a source language is the language basically of the individual that needs that you need to have interpretation for. The target language is the language that you would be interpreting it into, and so so it actually goes both ways. So if you're the interpreter and the English-speaking provider is speaking, then the source language is English. And the interpreter speaks Spanish, and the individual they're serving speaks Spanish, then the target language would be Spanish. If it's the reverse, then the source language, if the individual is speaking, the source language would be Spanish, and the target language would be English. Language of service is something similar. Language of service often refers to the language that's used by the individual being served. So in the case of what we're talking about today, particularly with Latinx communities, the language of service refers to Spanish. LEP is an acronym that's used widely, particularly by the public sector for limited English proficient. And ELL, English language learner, is used mostly in the educational setting obviously for someone learning English. Now, I nerd out on this stuff because, you know, language means so much. It perpetuates stereotypes. It can build support. It can shift people's ideas and thinking. And so, you know, when you're thinking about behavioral health, we think about using strength-based approaches. And when you talk about somebody being limited English proficient, there's a slight nod to this negative attribute, which is why the education sector started talking about English language learners, because the bottom line is that over time people do learn a language, at least somewhat, and over generations, of course, people become proficient in those languages. So ELL is something that's becoming more used across sectors, but because LEP is written in a lot of code and a lot of laws, it will remain in place for many years. I use the words encounter and session kind of interchangeably, and basically it's just the time period in which the interpreter is being used. So it's a clinical setting, an encounter, a session, all of those are kind of interchangeable. And then language access services, which I've already talked about a great deal, are really all those components of ensuring effective communication. So not only is it interpreting, but it's understanding plain language and making sure you're using principles of health literacy. It's signage, you know, how people navigate your organization. It's translated material. It's technological supports for people who may have disabilities. It's all of those things that make language, or make communication effective in your setting. All right, so one of your pre-test questions you saw, I want you to answer this in your chat box. Tell me again which relationship you think is most important. Interpreter and individual, provider and individual, or individual and provider. And I actually think because we shared the responses, the vast majority of you have got it right. In any kind of clinical setting or therapeutic setting, the relationship between the individual and the provider is of utmost importance. The other relationships, although valuable, are really just ancillary. So even when you've added that extra person into the mix, the most important relationship that the provider can protect is the one between themselves and the person that they're serving. Now, untrained interpreters are used a lot more than is really desirable, and there's a lot of reasons for that. It isn't only because organizations, are negligent in their ability to plan for services, but it has to do with the fact that we have a lack of professionally trained and qualified interpreters across the country, and it's not an excuse, but it's just a complex mix of forces that mean organizations struggle to find interpreters that are trained and ready to be used. So one of the ways that states and public sector can really address this is at that very broad level of looking at workforce development opportunities for interpreters, because just like home health aides and folks that are needed in professional settings, there is going to be more and more need for interpreters, and there will be less and less of them available as populations of people need more health support in healthcare settings. The reason that interpreters are untrained interpreters are so problematic is kind of seen in this little slide here. This poor woman who is really just a web click. She's not real. That we have this assumption that anybody who speaks a language can be an interpreter, and there's nothing further from the truth. Language is a complex thing, and a lot of people make assumptions about, their college courses that they've been able, that they spoke it and they got A's in college, so they can do some basic interpretation now. The problem is that the terminology is so different. And the reason that I'm so passionate about this is because I was an untrained, kind of born again interpreter. I took Spanish in college. My primary language is English. I took Spanish in college. I didn't even do that well, but I moved from Virginia down to West Texas, and I worked in human service agencies that were largely in Latino neighborhoods. And because I had spoken some Spanish and I had a college education, I was asked to do a lot of interpreting, both written and written translation and oral interpreting. And I did hundreds and hundreds of interpreting sessions in all kinds of settings, everything from court settings where, immigration statuses were being decided, or where custody cases were being decided, in healthcare where people were diagnosed with HIV or AIDS, in local community settings with homeless people, with substance use disorder. I interpreted formally for a family therapist, and thinking through just the hundreds of people that I've interpreted for, after I learned how to be a trained interpreter, I realized how many people that I probably interpreted incorrectly for, and what kind of impact that those incorrect interpretations may have had. It could have meant the difference between their ability to stay in the US or leave the US, or their ability to keep their children or not keep their children, or make decisions for themselves about their health care. And what I did by saying I would interpret without training is rob people of their own ability to make decisions for themselves. So I don't take it lightly. It is an incredibly important responsibility when you say that you can interpret for someone, and sometimes it means significant life events for them. So I have come to realize that when I thought I was helping people with their needs, what I was probably doing was making things worse for them. And all of these things were me in those early days. I hadn't had a language set proficiency test, so I didn't know what level of language I actually had in Spanish. Untrained interpreters don't have all the terminology that they need. In fact, we never often do, even in our native languages. We don't have the terminology in specialty areas, much less in another language, unless we've been exposed or deliberately looked to learn that terminology. Untrained interpreters often have no understanding that there are standards of practice that are used and have been shown effective for helping and enhancing communication in interpreting encounters. And many times, untrained interpreters don't recognize how their relationship with the individual could compromise the quality of the session. People choose to divulge information that they do based on who's in the room. And so without even knowing it, their sheer presence could impact how they're diagnosed or how they follow up with the treatment or services. I like to think about interpreters or interpretation in terms of quality assurance and risk management. This is something, super big, as you guys know, in healthcare all across the country. And we think about quality assurance and risk management in other communication issues. In fact, a lot of the data around illness and injury in healthcare is related to communication challenges or barriers like health literacy. And the irony is that we spend hours and hours in healthcare organizations, and we spend lots and lots of money recruiting and retaining qualified and certified healthcare providers. We make sure that we are working on forms and materials in other languages, or rather in English, in thoughtful ways. We require continuing education and certification for our staff so that we can ensure that they're addressing quality. And then we hand over all that thoughtful and certified and qualified knowledge that the provider is giving to someone that we don't even really know if they can communicate it. We don't know whether they have the language capability or the other assets that we need to apply what we're telling them to say to the other person. So this study really reinforces what I said earlier on the slides about untrained interpreters. It found that the average number of errors within a 15-minute encounter was 31 for an untrained interpreter, and that more than half of these errors were of critical clinical consequence, meaning that it would impact the patient's well-being in some way. Now, I ask you a question in all seriousness. You know, if you were using untrained interpreters, family members, or other or staff in your office that haven't been tested for their proficiency or trained in interpreting, do you want to give 31 erroneous messages to a patient or client that you're working with in a 15-minute period? Because if you're using that untrained interpreter, then this is what you're doing. You can ignore all of the years and hours of your own professional training, because what you're doing is you're handing all of that over to somebody that you don't really even know can say what you're trying to say in another language. So some of the ways that we know errors happen in interpreting was done, there are many studies, but I find this one particularly useful. It was done at the Center for Advancement of Urban Children in their pediatric department, and it was done during a 7-month study. It found that the vast majority of errors are related to omission, which means that the interpreter just straight up left out a piece of vital information or a word that was critical to understanding during the encounter. 16% interpreted with false fluency. This means that they appeared to have fluency when they were interpreting, however, they did not interpret accurately. 13% of untrained interpreters replaced words or substituted words, maybe perhaps because they didn't know them. Maybe they didn't know that there's a difference between a hallucination and a delusion, and so they used the word in the target language that meant the other. Or someone said that that a person was going to have an assessment instead of a screening because there was no understanding of the distinction between the two. Or they called a CAT scan an MRI. Those kinds of things happen when an interpreter doesn't recognize that the distinct word being used can have an impact on someone's understanding. 10% of these errors were related to editorialization. We're human and we're busybodies usually, so we always like to add in what our opinion of things are, but a professional interpreter understands that the dynamic created by that adding in is different than if they were just a family member or a friend. And then 8% of people added words or phrases to what was expressed by the patient or the physician, which means that what the patient or the physician said wasn't really interpreted the way they said it. And so the study really concluded that errors in medical interpretation are very common, and that most errors in interpretation do have potential clinical consequences. Now, it goes without saying, for those of you who do clinical work and out of fear of insulting you, it goes without saying that we just never ever use children as interpreters. There are so many reasons why this is problematic. The challenge with the imbalance of power, all of a sudden the child becomes the person in the room with the most power over power, with quotation marks, over and above their own family member or the provider. Children are immature. They don't process things the same way that adults do, and thus they would not interpret things the way adults do. They're still learning the language of English and probably learning the language in their home as well. So they don't have, even though they're native speakers of both languages, perhaps they don't have the proficiency that's needed. It makes a child incredibly uncomfortable in the role that they have to play. And then it negates confidentiality. Every person seeking assistance in healthcare deserves to keep information from whoever they decide they need to keep it from. And if they are using their kid as the interpreter, it certainly does not protect their confidentiality. On the other hand, there are also many studies that talk about how trained interpreters do improve health outcomes. I want to go over a few here on the next page. Some of the ways that we know trained interpreters give us an advantage is that they allow for the patient's full comprehension, right? If the person understands what's going on, the better they're going to be able to make decisions about their own circumstances. It allows the patient to have consent and autonomy. When an individual doesn't understand everything that's going on in their own healthcare setting, it robs them of their autonomy. And in the US, we value that as a critical value. Self-direction, self-determination, independent decision-making are things that we value as a culture in the United States. And when we don't give people the information they need to make those choices, we're really robbing them of a true American value. Interpreters indirectly help patients with their health literacy education. They learn by kind of default more about how the US healthcare system works. Because communication is more effective, less diagnoses or less tests are often needed, and this is the case in behavioral health too. From my experience, interpreters help allow for more effective assessments the first time, as opposed to having to redo assessments several times to make sure that people can get a true diagnosis. Of course, it helps with more health history and with the greater ease of diagnosis. One interesting study about the use of trained interpreters for me is this one from the National Cancer Institute. And they detailed that when trained interpreters were used, that they accurately interpreted 74% of the time, and that the errors that were made had less clinical significance for patients than the errors that were made by untrained interpreters. One thing I think is really important in this study for practical application is the fact that they also found that interpreters who are interpreting during non-technical interpretation are much more accurate than when they have to interpret highly technical material. So this supports the idea that people who interpret for us in distinct fields or with technical arenas, which I would say are like, psychotherapy, developmental disability diagnoses, those kinds of things. It really supports the idea that we provide them as an organization with the specific terminology that they need to use in our disciplines, because the more they have understanding of the terminology, the better they're going to be when they do have to interpret highly technical items. All right, so let's talk a little bit about the common practices of trained interpreters. Language interpretation is a formal profession, and it is a practice profession. It is a profession that's really in its infancy as a language profession. Now, interpreters for the deaf and hard of hearing and late deafened have a much longer professional history. They've been forming their profession for decades now, but language interpretation is probably only about 20 or 30 years old as a formal profession. And as such, trained interpreters follow routine protocols They're expected to have a specific set of skills in order to do their work. They're expected to follow a code of ethics, and they're expected to recognize and utilize standards of practice that have been proven to work most effectively. Now, again, I said my opinion is that the more providers who use interpreters know about the profession of interpreting, the better they're going to be able to support effective communication in their own job. The better they're going to be able to hold interpreters accountable for their level of effective communication. And the better they're going to be able to distinguish between when they're using a highly trained interpreter and when they're not using a very good or poorly trained interpreter. The provider shouldn't feel stuck with a bad interpreter. They shouldn't fall victim to the idea that they just have what they have and they don't really understand what's going on because they don't speak the language. Interpreters who are following these specific standards of practice, you'll be able to see those and recognize when they're being used, whether you speak the language or not. And being an interpreter is really more than just speaking the language, as I think we've already made clear. You know, along with speaking or needing the language skills and really highly proficient language skills, truly bilingual in 2 languages, you have to have a really good memory. You have to be able to remember strings of sentences sometimes and then be able to speak them in another language pretty quickly. You have to be able to, right in the moment of time, find an equivalent meaning for each language, even when that word may not exist in another language. And this is all done, you know, at a rapid pace. You got to have that specialized terminology we talked about. And for an interpreter, I mean, you guys as providers talk about it as being a therapeutic relationship or building a relationship with the patient, but for interpreters it's really a focus on customer service, understanding where their role is in an encounter and making sure that all of their customers per se, the patient and the interpreter, are given what they need to maximize the quality of that individual care. So a few little kind of in the weeds things about interpreting. We talk about the modes of interpreting and we talk about the roles of interpreters. So when we talk about modes of interpreting, we're talking about how an interpreter may go about transmitting information. The most commonly used type of interpreting mode is consecutive, and that is what you typically see where someone says a sentence or two, they pause slightly, the interpreter transmits it into the next language, they pause, another person speaks back in their language, the interpreter and pauses, and so forth. And that is the kind of the preferred mode. It's the way that most information can be effectively transmitted because there's a little time to gather it into your brain, change it into the next language, and spit it back out. Simultaneous interpretation is not as common, but it's probably fairly common in the settings that you guys are in, which is behavioral health. Simultaneous interpreting is used in healthcare often when there's a need to speak rapidly. So in maybe an emergency situation or a crisis situation where people aren't able to pause or people don't have the wherewithal to pause, the interpreter is maybe just slightly behind the person speaking, kind of repeating what they say in another language as the person is speaking. Very difficult for some people, and some interpreters kind of love the challenge of simultaneous interpreting, but it requires a lot of brain power. Sight translation is usually done in settings where there's maybe less than a page of information that needs to be shared with the individual, that doesn't require a signature or doesn't require them to be able to retain information. Often it's like an appointment card. You're reading out the appointment card in the other language. If it's a longer document, or if it's a legally binding document, or if it is a document that somebody's expected to go home and retain and maybe refer to for further information like discharge papers or something, a sight translation is neither useful, and it also, if it's got a legally binding aspect, it doesn't hold up in court because you can't require somebody to sign something in a language that they don't speak. And then relay interpreting is often used in interpreting for the deaf, but it is used from time to time in language and foreign language interpreting. And it's the idea that, say, someone speaks a dialect of, let's say they speak a Mayan language, and there is no interpreter really that speaks this Mayan language, but there's a family member, say, who speaks the Mayan language and Spanish. And so you'd have an interpreter interpreting from the Mayan language to Spanish, and then maybe you'd have a trained interpreter translating or interpreting from Spanish to English. And then you kind of go around the room in this relay way, because there aren't always interpreters available to speak every possible language and dialect out there. We talk about interpreter roles too. This is, I think, very important for providers because it helps them recognize how an interpreter will shift from one kind of responsibility to another. This graphic here is from Kaiser Permanente's training that I did with them for quite a while, and they call it the interpreter highway. An interpreter is trained to be a conduit most of all. More than anything else, what they're doing is being a conduit of information. Their goal is to kind of disappear into the background and just help transmit information. And so in any given interpreter session, they are rolling along on this conduit lane, helping just to transmit information, message converting from one language to another. And then perhaps something comes up about the register of a word, or the way that a word is used that may not be as easily understood in another language. So the interpreter jumps over here to the lane where they have to clarify a message. And they're not doing anything else but maybe changing a word to another word that means the same thing, or they're adding perhaps a sentence that helps the person to understand what the message is, or they're shifting the way that something is being said. And then once they've clarified, they go right back to the conduit role and they keep plugging along. And then say during the same encounter, something culturally comes up, some cultural nuance related to the discussion that the provider and the individual are having. And the interpreter recognizes that perhaps this cultural nuance isn't widely known among both parties. And so they'll jump over to that cultural broker role, they'll do a little clarifying of some cultural nuance, then they'll jump right back to their conduit role and keep rolling. And then very rarely are trained interpreters encouraged to run in this advocacy lane. Trained interpreters are taught that you intervene as an advocate only when the person's health or well-being is being challenged, or when there's just structural or some sort of inequity or racism that is being put on the individual being served. This is a key point because untrained interpreters often operate in this advocate role, as a default, and what it does is creates a much more intrusive intervention than what we know in the research to be the effective role of an interpreter. Another way to think about this this highway is this triangle, and really trained interpreters recognize that their whole purpose is to be in the background, right? So the least invasive way that they work is through the conduit. And as they move into these different roles, they are becoming more and more invasive. So as you go up the pyramid here, the interpreter stays less and less in the background and becomes more of the center of attention. And that is the least favorable role for an interpreter. A good interpreter is never the center of attention. And we'll talk a little bit about why that is in behavioral health in a few. All right, so let's shift a little bit more and we'll talk about how you as a provider can use some strategies now of what you know for trained interpreters and help you work with untrained interpreters. You know, most of us have to work with untrained interpreters, whether we like it or not, at some point in time. And it is possible for you as a provider to ensure effective communication, even if you have to work with an untrained interpreter. It's all about how you can direct them and sort of set expectations for that untrained interpreter in your encounter. So this is a little more conceptual, but I think you guys as behavioral health providers will really appreciate this concept if it's not already familiar to you. I want to describe the difference in the dynamics of a health encounter when an interpreter is being used. And this is kind of described as what they call the psychotherapeutic triad model. And it represents this dynamic, this change dynamic of when an interpreter is in an encounter. You know, when there are three people are working together using two different languages in a structured task, three different interactions are occurring, often all at the same time. What develops is a triangle with these three sets of pairs or dyads, each one that's operative at any given time, and sometimes all along in the encounter. So if you notice here, the relationship between the provider and the interpreter is both verbal and nonverbal. The relationship between the interpreter and the client is both verbal and nonverbal, but the relationship between the provider and the client is only nonverbal. So the model reminds us or helps us really to recognize that the simple addition of a third party inevitably shifts the dynamics of power between the individual and the provider. And it reminds us that the only one in the encounter who really has full access to what's going on at any individual or any given time is the interpreter. So the power shifts to the interpreter in this triad because they're the only ones that know what's going on all the time. And it does funny things to the provider and the client. Even the most self-assured provider often struggles with how they're going to manage not knowing everything that's going on in the room, which is what they typically are able to do, and how they use that interpreter. And to be honest, many times what happens is that the provider tends to defer to the interpreter as much more than a conduit for information, but rather as a consultory support system in ways that they really don't have any knowledge or training to be. If you have had this kind of thing happen, or if you have thoughts about this, I'd love for you to throw it up in the chat box. It's an interesting dynamic that some people are totally aware of and recognize, and some have never even thought about before. So feel free to throw some things in there your thoughts as you come to think about them. Now, so how do we manage that difference in power, that immediate shift in who kind of quote unquote has the power in the setting? How we do it in using trained interpreters is through using these certain principles and guidelines. Professional interpreters and trained interpreters describe how we can quote unquote manage the setting using these 3 phases, what we call the pre-session, the during session, and the post-session. And we're going to talk kind of quickly about each one here. In the pre-session, it doesn't have to be long. It can be just a few minutes. It's a moment in time when the clinician can catch up with the interpreter and sort of share the game plan. The more the interpreter knows, the more neutral they can remain if things that are unusual to them come up. The clinician should share as much information as they can with the interpreter. HIPAA rules allow for interpreters to be considered a part of the healthcare team, and so sharing this information with a trained interpreter is not a violation of HIPAA. And the interpreter, as a result, will also share any information that they may have come across, say, sitting in the waiting room waiting for the encounter, or whether they've, passed or happened to meet the person in the parking lot, or if anything kind of unusual comes up that would help the provider in the encounter. Now, during the session, the provider, whether they like it or not, of course, they're still responsible for building that relationship with the individual being served. The provider, the interpreter, will not come in with the expectation that they have to help the provider build that relationship. So during the session, it's really important that the provider recognize how they can maintain control of the setting. And one really important way is to talk directly to the patient. I can't tell you how many times I've sat in a session where the provider talks directly to the interpreter as opposed to the patient, and just the subliminal messages that sends to the patient are so complex that they don't matter, they're not there, they're not really the one that is important, etc. To help the interpreter interpret effectively, talk about one issue at a time. The provider can pay attention to how long the interpreter speaks or how long the client is speaking, and if something is long-winded on one side and then all of a sudden the interpretation is only 10 seconds or something, the provider has the right to ask for more information. The provider has the right to expect the interpreter to share anything that they have discovered while communicating. The provider can watch for the patient's tone. So even if you don't speak the language, body language is such a huge part of human interaction that if the body language changes, if the voice tone changes, it may be a signal that something is not being communicated well or needs clarification. If a response doesn't make sense to you, you have the perfect right to ask for more information, for the interpreter to describe more. And then, just remember that there are a lot of concepts that are not directly translatable into English, and vice versa. And so the more the interpreter may have time to process in their own brain what the concept is, the better they're going to be able to describe it in an accurate way. So just realize that this may take more time than a setting without an interpreter. Now the post-session should, again, it can be 5 minutes or so. It doesn't have to be long, but it's just a check-in. It's an opportunity to pick the brain of the interpreter for any cultural issues that they may have seen, and it offers an opportunity for the interpreter to share any information that they may be concerned about. So we talked about these roles and these responsibilities, and there's a very wise interpreter trainer here in Virginia. Her name is Rosemary Rodriguez, and she has an interpreting company, and she's done a lot of training for my communities over the years, and she reminds professional providers that an interpreter is responsible only for facilitating communication and only ensuring completeness and accuracy. We often rely on interpreters for so much more than this. We ask them to be the chaperone of the patient. We ask them to sometimes be a support system for the patient or the client, and these are jobs above and beyond what the interpreter is being called to do. So if the interpreter is just supposed to facilitate communication, then what do we as interpreters expect out of the provider? A lot of this I've already kind of said in the pre-session and post-session and during session. But the more you can give information to the interpreter about what's about to happen, or what your therapeutic process is or your philosophy is, the more they are going to be able to manage their own emotions, their own response to whatever's going on in the room. Providers really need to avoid using slang or specialized language or acronyms. Can't make an assumption that the interpreter will know all of those. We say things so casually that we don't realize may not have a interpretation. Things like, barking up the wrong tree, or bromance, all those terms that we kind of use and assume people know are not necessarily translatable. Also things like ASAP or ASAP, get that back to me ASAP, or PTSD, all of these things can really trip up some interpreters. So just to beat a dead horse, really, an interpreter cannot serve as a clinician, a diagnostician, a decision maker. And ironically, that happens a lot because of the power shift in an encounter. But you can recognize that they have cultural and language expertise that you may not have, and that you really should take time to tap into that through these pre-encounters and post-sessions. So working with an untrained interpreter, you want to give them some expectations at that pre-session. You want to tell them that you expect everything in the room to be interpreted, that transparency is one of the most important things, that they tell you everything that's going on. Ask them to speak in first person. First person will allow sort of the ability for the interpreter to move into the background, because you're using the words you and I instead of he or she. Speak at an even pace in short segments, especially for untrained interpreters. That can help. Avoid that slang that we just talked about. Don't hold the interpreter responsible for what the patient does or doesn't say. Recognize that people, if they feel uncomfortable or if they can sense something in the room that's a discomfort, they may decide not to divulge certain information. Again, be aware that the concepts you express may have no linguistic equivalent, and encourage the interpreter to share with you if there are cultural things that come up. Culture operates underneath the surface of our subconscious, and so oftentimes even people who understand a cultural nuance doesn't realize that they could share it with someone else who may not know it. A lot of what I just described here holds true for interpretation in mental health settings as well as just regular healthcare settings. And again, the more an interpreter knows about behavioral health settings and what happens in them, the more they can manage their own responses to difficult situations, and the more a clinician knows about the nuances of interpretation in behavioral health, the better they're going to be able to utilize interpreters. So some of these last slides here are just explanatory or conceptual in nature to get you thinking about the different ways that you use interpreters in a mental health setting. I really like this quote because it frames the tension that's present when we think about the connection between behavioral health services and interpreting. You know, Dr. Pollard here is a leader in thinking through interpretation for the deaf in behavioral health, and he's done a lot of work around the dynamics of interpretation in behavioral health. And he really, you know, shares that our field, the behavioral health field in general, is unique among medical fields because most of the symptoms are conveyed by and through communication. And without good communication, we really are at a disadvantage in this setting in particular. Another concept that I think is really important, and it's not often discussed, is how language impacts individuals' self-identity and their recovery and their self-talk. So, you know, in the US, our language evolves all the time as it relates to mental health and developmental disabilities. And we recognize that language can dispel stigma, or it can reinforce stigma, that it can help with self-defeating thinking, and it shapes our thinking and our behavior. Now, if our interpreters do not understand the words that we choose to use so that we are supporting people in recovery, then they are perhaps using words that actually perpetuate stigma or support kind of self-defeating thinking. And I'm thinking of a lot of words like, you know, drug addict. You know, that's a common word still used in many parts of the world, which means that for an interpreter, that may be a perfectly appropriate word to use. In the US, that's not a word that we use often. Things like mental retardation, we don't use that in the US, but it's being used all over the world, and interpreters, unless they know sort of that approach, they don't understand that the language they're using may or may be detrimental to people. And language is directly connected with emotions. There's a wonderful study done by the University of North Carolina that studied words describing emotions in more than 2,000 languages, and they found significant variation in how emotions are expressed across cultures. There are many words that have no equivalent in other languages. One great word in Portuguese is saudade, which means a deep melancholy. It has no English counterpart. They use a word, they talked about the word in particular, grief, and described how Persians in Iran use the word aunda to express both concepts of grief and regret. But meanwhile, in the language of Dargwa, which is in Dagestan, the word dard indicates grief as well as anxiety. So what this means to people in the US sort of trying to conceptualize emotion is that Persian speakers may understand grief as more similar to regret, whereas a Dargwa speaker may understand grief as more similar to anxiety. And these two distinctions are very important in mental health. If you have words that you recognize, please put them in the chat box. And also, I'd love to hear from you guys about why you think these distinctions are important in behavioral health. So throw those up there if you don't mind. I'll give you one. There's a word in Spanish that has no English equivalent, vacilando. Vacilando typically means something similar to the trip is less important than the experience of taking the trip. And it has a great deal of emotion in it, and it doesn't have an English language equivalent. So when we're thinking about clinical assessments, there's two things that that I think are important. You have to recognize that interpreters are humans, and as interpreters, our role is to clarify information, right? So our whole job is to make sure that people are understood. And so it's not uncommon in psychiatric settings that the interpreter really wants to normalize the patient's psychopathology to protect, the patient or protect their role. If interpreters may sometimes fall into a trap of trying to decide what best makes sense, even if there is a patient who has disorganized or illogical responses. So as a clinician, it's important for you to let folks know that it's okay to interpret things that necessarily don't make sense. In group settings, or in therapy rather, I think there are a couple of things that are pretty useful. There has been some, not studies, but practitioners' responses to how useful interpreters are in therapy. And we use interpreters a lot in group therapy, but we don't have a lot of information about how useful or how effective they are for the individual seeking services. And what practitioners have described is that there isn't a whole lot of utility in using interpreters in a group session unless they're in certain scenarios, and those scenarios tend to be scenarios that where they don't perhaps need as much interaction, like so maybe support groups where there are multiple people who speak the same language, or maybe it's groups that are staff intensive. And so there's a lot of interaction with one person, and maybe educational groups where folks work independently on tasks, so that the interpreter is really just helping one person engage with one other person. Another important concept here with interpreting in a mental health session is the idea of this neutrality myth. Now, my perspective is probably that this is recognized by a lot of behavioral health providers, that that interpreters can't be as neutral as we expect them to be. Metzger, the person that wrote this book, described or coined rather the term interpreter paradox, and that's the idea that although interpreters have traditionally attempted to be neutral, that's how we're trained, a number of studies show that we just simply can't do that. We're human, and it means that we just simply can't always act as a conduit of information, especially when things are highly complex or emotionally charged. We have a relationship with people whether we want to or not. So the neutrality myth argues that interpreters have kind of the both conscious and subconscious power to influence discourse just by their sheer presence, and it'll be up to providers to kind of manage how that relationship or that discourse happens when there's an interpreter in the setting. Now, the last thing I want to talk about before we wrap up is the vicarious or secondary trauma that can happen to interpreters. Just as I said early on with interpreters working in COVID, interpreters are not trained to process pain and trauma the way that healthcare providers, particularly behavioral healthcare providers, are trained. They also don't often have the opportunity to debrief with people. There aren't processes in place like there are with behavioral health providers to share traumatic experiences or to learn how to do self-care. So whether you like it or not, it is important that you as a provider, because you're a human being, you help support your interpreter if they have just completed a traumatic or a highly complex or emotional encounter. And some of the ways that this can be done best is providing training, allowing for organizational training for interpreters. Things like learning about psychological symptoms, therapeutic processes and dynamics, learning the basics in therapy, opportunities to learn specific vocabulary. There are all kinds of resources for interpreters that you could have in your organization. These happen to be just two from an organization on the West Coast called Cross-Cultural Healthcare. There's a Spanish-English mental health glossary, terms and definitions of mental health. Having those things around for people is very helpful. And I have 1,000 thoughts on this topic, which is why these bubbles are all crushed together. But really, a couple of last things I want to make sure that we emphasize is that we rely on interpreters to be successful when we're working with individuals who don't speak English. We can't have effective diagnosis and treatment if we don't have a good interpreter. The meaning of language is complicated and exact translations are often rare. In fact, I don't think there's a time when you can have a perfect translation of an entire encounter. Interpreters don't always have an understanding of how communication is impacted by cognitive, emotional, behavior, and social factors. So if you're working with interpreters in highly complicated behavioral health settings, you're going to want to give them some information about that. And then the more jargon you use and the more complex technical terms that you use, the more difficult interpretation is going to be and the less successful really your encounter is going to be. So those are my thoughts, and I think what we should do is come back to you guys. Isa?
Yes, we have a couple of questions for you. Making sure I get the right one. Okay, the first one says, which are the recommendations about the use of interpreters while providing mental health services through telehealth?
Some recommendations. Well, actually, it's really a lot of these same things. You're going to want an interpreter who is familiar with working virtually, that is going to be trained as a professional interpreter, that's going to have the terminology that you need, particularly in behavioral health. And if they don't, or you can't often guarantee, then your organization or you individually can provide them with some resources like glossaries or treatment modalities that you use in advance. So, I would consider, you talking with the interpreter before the encounter, even maybe, setting up a quick meeting. Now, they work hourly typically, so you can't take up a whole lot of their time, but finding a way to engage with them, to give them the expectations they need, and then make sure the technology works well, the internet works, the sound is up, all of those logistical things you do for any telehealth setting.
Awesome, thank you. Okay, I'm reading this next one. It's kind of long. It says, was the responsibility of the Spanish-speaking media, Univision, local radio shows, etc., to inform Latinx about COVID? I'm a Chicana therapist, and I'm upset about how limited these lifelines do to inform and support our population? What's your take on the media's role to help our fights?
Well, so I'm just going to say this is Cecily talking, Cecily's personal opinion. I don't represent the National Hispanic Latino MHTTC or Virginia Tech, but I think the problem is larger than that. I mean, our news in general is all about drama, and that's what brings in the ratings. And so those real helpful things often get put to the side so that we can have our drama. And yes, indeed, I agree. There ought to be more attention placed on getting the real tangible information out across media sources.
Thank you, Cecily. And then I think this one's really interesting. It talks about the fact that there are 27 different ethnic groups in the US, and how does culture or idioms impact the communication and clinical work in clinical settings when using the interpreters?
I assume they mean 27 different Spanish-speaking ethnic groups, so maybe perhaps dialects and cultural differences among them.
Yeah.
It's a great question, and it also lends to the fact that we have issues around the number and the kind of interpreters that are available in the workforce. And of course, you can have cultural competence without being from a given culture, but it requires training and practice. So making assumptions about an interpreter being culturally competent because they've had interpreter training is one thing. Ensuring that they are culturally competent is another. So just because, as you're saying, someone is Latino doesn't mean that they understand all the cultures of the Latinx community. So organizations have to hold interpreters accountable for their cultural competence as well as their language skills. And that requires them to be engaged in understanding cultural nuances among those 26 ethnic groups within the Latinx community. Hope that answered the question.
Yeah, I think it did. Thanks, Cecily. Before I ask the last one, because we're a little bit past 2:30, I just want to remind everybody that on the chat box, we, I missed the word. We shared, sorry, the evaluation link and a couple of information about the certificate and all that. So make sure you guys are aware of that. Everything's on the chat. And our last question says, if my agency doesn't offer official language interpreter training, how can I access such a training type of program so I may adapt these tools to work for the clients I serve at my agency? And could this be accessed like as free training programs?
Well, there's a couple of responses there. One, if you are what we would call a bilingual staff person, and you have another job and you're being used as an interpreter from time to time, there's a level of advocacy that you'll have to do for yourself and for your agency to ensure that you as bilingual staff are trained to be interpreters. It's not easy. I've worked with a lot of individuals who are bilingual staff who are challenged by this fact that they are asked to do this job without any training. Having said that, there are a lot of resources on the web for how to better provide interpreting services. There's hundreds of YouTubers that talk about this. There are folks who do weekly podcasts. There is a lot of written material related to it. And for a person doing kind of informal continuing education, those things are great. If you've never had any training and you've never been tested for your language proficiency, then just doing those kind of online self-learning things are not as useful. Like I used with my own story, I did ultimately become a trained interpreter and had a proficiency test and all of that. But before you have that, you really don't know what your limitations are for interpreting. So, you know, if your organization isn't doing it, then perhaps you pay to get a language test on your own. And then you use that information to advocate for yourself about the levels of interpreting complexity that maybe you have the language proficiency to do. I don't know of any free interpreter trainings across the country, but I do know that here in Virginia, the former agency I worked for does have has interpreter or bilingual staff training from time to time that's open to community mental health settings and education settings and the like. And so perhaps there are other state agencies across the country that do the same. I could talk about this for much longer, but I know that we're at the end of our time, so I'll turn it back over.
Thank you, Cecily, and thank you everybody for joining us today.
Thank you
That's
so
all
much.
the time we got, but I wanted to thank you for giving us so much information, because it's definitely real good information. We had a couple of more questions, so I'm not sure if people want, they could just email us and we can pass it on to you, because we had a lot of questions for this one. So just everybody, thank you again. This webinar will be available in a couple of days on our YouTube channel. And if you don't follow us on social media, make sure you find us as ILA MHTTC. And I hope everybody has a great day. Cecily, once again, thank you.
Thank you so much. Bye-bye.
Bye, everyone.
Thank you.